by the Gastro Foundation in conjunction with Project ECHO at the University of New Mexico. My name is Chris Cassanides, and I'm in Johannesburg on a glorious winter afternoon, and I'm standing in for Sandy Thompson, who's in Nigeria. It's a great pleasure this afternoon to introduce to you Vikash Lala, and also the GIEQs training platform, endoscopy virtual training platform, which the foundation has endorsed and also would like to spread out and advertise as the platform, the virtual platform, which we feel gives you the best quality in training, endoscopy training, quality control, and upskilling. GIEQs stands for the Ghent Endoscopy Quality Symposium, International Endoscopy Quality Symposium. It's a bit of an unfortunate name, but really it gives you great quality as far as training and upskilling is concerned. And to do that, I'm going to introduce Vikash Lala to you. Many of you have come across him in the last few months. He's a graduate from the University of Witwatersrand, spent 6 months at the University of Ghent in Belgium with David Tate. And he returned towards the end of last year, and really in just a few months has really excited the endoscopy community, not only in Johannesburg, but in other centers in South Africa. He's skilled in advanced endoscopy, is based in Johannesburg at the Charlotte Maxeke Johannesburg Academic Hospital and the Wits Donald Gordon Medical Center. And we are very, very fortunate that he has returned to South Africa. And I'm also very pleased that we had an opportunity to support him in his stay in Ghent. So over to you, Vikash, and we'll take some questions on the platform. And if you really want to pose them verbally, please unmute, put on your video, and feel free to ask questions. Over to you, Vikash.
Thank you, Prof, for that very kind introduction. Yeah, as you mentioned, so I was fortunate enough to have the opportunity to train in Europe, in Belgium, and follow my passion essentially, which is endoscopy. And it took me about 2.5 years to actually get across. I had the intention to go at the end of 2019, largely because of COVID, but many other challenges. And at the time, I was super frustrated and so almost gave up. But in hindsight, it was actually a blessing in disguise. And the reason why it was a blessing in disguise is in that 2.5 years, I was able to actually elevate my baseline skill to the point where I could get there and get more out of my fellowship. And in that time, I actually got introduced to the GIEQs platform. And I actually myself personally benefited quite a lot for it. And that's the reason why I promote it. It's not only because I've trained there and I do have a certain bias towards the platform. I am also part of the scientific committee for GIEQs, but I personally benefited it from quite a bit. Essentially, GIEQs is an online encyclopedia or library, or call it what you will. It's a collection of hundreds of videos of all real life endoscopy practical cases. And the focus is really on quality. It draws on principles from advanced endoscopy and applies those principles to basic everyday endoscopy. And you'll see that I've been using the term or the phrase, there's endoscopy and there's quality endoscopy, and you'll see where that comes in. Lots of the time, we as endoscopists end up just, we just that a resource to get tissue in that big fungating tumor, and that's not really where we're adding value. We need to be performing quality endoscopy and preventing that big tumor. So it's a platform with many, many videos, and it can be a bit confusing to use. So I'm going to just run through the platform and show you how to easily search from it and how to gain the most from it, and then actually play some videos from the library available on the platform. The issue is that we've all read guidelines, and there's hundreds of different guidelines, ASGE, ESG, ACG, And the guidelines will tell you why an Ovesco is better than a clip or why we use dual modalities. But the one thing all of these guidelines lack is, number one, lots of these data come from expert centers. And the one hidden variable that's not being addressed in these guidelines is technique. So they'll tell you maybe an Ovesco is better than a clip or etc. The snare is better than that or whatever it may be. But it boils down to technique at the end of the day. A poorly placed Ovesco is no better than not treating anything. So at the end, that's the hidden variable that's not addressed. And that's what's being highlighted on this Geeks platform. So basically, on the Geeks platform, you'll see that they run a whole host of courses during the year, and in 2023, it's quite jam-packed with a course almost every month, and basic things from colonoscopy withdrawal, upper GI lesion assessment, to some of the more complex things with more complex EMR, third space endoscopy, and ESD. And the highlight of the show is the annual symposium. So they have in addition to the webinars, they have an annual symposium, which is labeled Geeks and Symposium. And this year would be the fourth edition, so Geeks 4. And you can see it's a 2-day symposium and with a stellar international cast. And going over quite what we would think is simple topics, but the way they deconstruct it, you will soon realize that there's a lot more to it than we ever believed. So a lot of the principles on the videos that are on the Geeks website is based on the principle of deconstruction. And you'll see it's not just watching someone do an EMR, but it's rather deconstructing the EMR to the point where you're discussing the position of the patient, the position of fluid, of gravity, the fold, whether the fold is lying uphill or downhill, the position of the scope, the proximity of the scope to the lesion, the plane in which the snare is lying, the opening and closing of the snare. Is the snare not open enough? Is it too open? How do you close the snare? The lie of the snare, critiquing each and every fine detail in terms of where the wire of the snare is placed. And you just simply don't get that in endoscopy-based webinars. Everyone's just showing you the latest ESD technique or the latest traction device, which is going to take years to get to our shores and become relevant. So it's quite relevant. This is just some of the cast from the last year's Geek Symposium. I was fortunate enough to be there at the time and be involved in it. And you can see there is quite big international names. Professor Michael Burke, one of probably the most published polypectomists in the world. Prof. Burgess, John Anderson, well known for his quality in colonoscopy and Train the Trainers course, and a few more familiar names there as well. And so I'm sure we can expect the same sort of quality in this year's Geeks webinar. Just a disclaimer that it is a paid for membership. So if you look at the bottom here, that there are different types of memberships and there is a free membership. But in order to gain access to all past as well as future webinars, you need a paid for membership, either a standard or a pro membership. And in my opinion, that small fee to pay for it is really worth the price. The reason why it's paid for, it's a charitable or based organization, but I can assure you there is an immense amount of work which goes into making videos, editing videos, uploading them, hosting the server, maintaining the server, running these live webinars. This is the David Tate. So he's the main founder. The other co-founders of the website is John Anderson and Roland Valerie. I'm just going to play this quick clip from David. He unfortunately couldn't join the talk today, and that's because they're actually hosting a live ESD ESD training course today, which is also accessible on the platform. I'll show you that.
No sound. Or is it just me?
Just let me.
It actually stands for the Ghent International.
Yeah.
Let's just get it.
My name is David Tate, and I'm one of the doctors here. GIEQs is about quality in endoscopy. It actually stands for the Ghent International Endoscopy Quality Symposium. But of course, this is a website, so it's not a symposium, but it's the whole idea of how can we do our everyday endoscopy better? How can we get across the ideas of complex endoscopy, of complex interventional endoscopy, and bring them to a audience that is wide, that is doing everyday endoscopy, and how can we make everyday endoscopy better for our patients? That's the idea, that patients get a better experience through this endeavor. I hope you'll join us. I hope you come in and see all of the interesting material that we have here. Eventually, we hope to make this a collaborative endeavor where you can contribute your videos and your ideas as well. And that's the second phase. So we look forward to welcoming you then.
Yeah, so that's David. And so let me just take you quickly to some of the workings of the...
So Vikesh, before you proceed, I think to emphasize that there are many programs, as you said, in the world that give you a lot of teaching on advanced endoscopy or endoscopy that's not really basic. But the reason why this really caught our eye, the foundation's eye, is that they really do concentrate on basic endoscopy, which is what we do need on this continent. And it's also the deconstruction of the absolute basic techniques that really are amazing to go through. You know, after I watched the colonoscopy withdrawal one, I mean, it immediately changed my practice at the next colonoscopy I did, not a month, 3 months later. It was an immediate transformation in what in the techniques that I did. And I think those are the two things we really want to emphasize, is that it covers all spectrums, but it's the basic nature of this of the procedures that they go through that is so admirable.
Absolutely. That's what I did as well before going across to Ghent. I watched many of the videos and would just essentially try it at my base hospital at Charlotte Matseke. And yeah, it certainly benefited my practice. So there's different ways to search for content on the website, and you'll see different tabs on top. You may start off at that tab, and then you just click on online education. And it takes you to these tabs here. So one of the ways to search is essentially just to search. So you're on call and you know there's a GI bleed coming and you're thinking, oh no, I haven't used a Novesco for many months. What am I going to do if I need to use a Novesco? You simply just want to look through videos. So you just go to the search function and you'll just type rather over the scope. So you just type for over the scope clips. And you'll find the tag come up. You click on the tab and you'll see multiple videos demonstrating the use of a Novesco. For example, I'm just clicking on one of them. So basically the way the website is, or the way the videos are, they divided into chapters. And you can see that the chapters are labeled. So that's difficult visualization, cold snare ligation of the clot. And the videos also, there's hundreds of different tags. And if you search for a tag, it will pull up all videos with that tag. So there's tags on snare closure, on polyp assessment, on Kudo, on JNet 2A. If you don't know what the JNet 3 lesion looks like, you just search JNet 3. It will pull up all the videos with the JNet 3 lesion, and it will take you to the place in the video where the tag has been placed. So in the chapter where the tag has been placed. What I actually was going to do as the talk for this week was pedunculated polyps. So let's just use that as an example as well. So the one issue I've noticed is that many people struggle with using an endoloop for pedunculated polyps. So you want to you want to search pedunculated polyps and you want to know how to use a polyloop or an endoloop. Simply enter the tag and you'll see multiple examples come off. Just to note that there are also nursing videos. So this is a nursing video on the nurses actually demonstrating how to deploy an endoloop. This video, in my opinion, is pure gold. It's really does break it down and show you how an endoloop works, and it's just invaluable. So I think it's not only for clinicians, but nursing staff and assistants certainly stand to benefit from it as well. So you go into your pedunculated video and it will take you automatically to the section in the video where the tag is. And you
so
can
the
then
nurse has
watch
to be
the content
on their game. And again, we have some nursing videos on how.
So the other way to search is simply just to go to the Explore tab. And today you just feel like looking at something in polypectomy, and you can see a whole lot of different polypectomy tabs come up. Then this is where the courses or pro content comes in. So again, this year, there's about 9 or 10 courses over the course of the year. And you can see there's multiple polypectomy courses. There's basic colonoscopy courses. These are the past symposia. These are the upcoming courses. These are the courses which were done recently. So at the moment or today, they were running the ESD course. And there's other more complex courses as well, including the third space collection, the advanced EMR course. The other utility of the website is not only for trainees and for people wanting to learn, but there's a lot of content that aims at training trainers. So there's a lot of the trainers content with regards to basic colonoscopy, but also with regards to EMR. You can actually watch trainers training trainees how to do EMR and deconstructing EMR. So quite valuable content. So I'm going to take you through just some snippets of some of the content of basically the two most recent courses that were held. And the last two courses that were held was this colonoscopy, the withdrawal course, sorry, and the upper GI course. So let's just go through the withdrawal course, and I'll just skip through some areas of the video which I think highlight the aspect of quality in endoscopy. Okay, so I'm just going to let it play.
Now, the WHO a few years ago categorized the root cause of these post-colonoscopy colorectal cancers. And I just want to dwell on this and maybe introduce David and John to comment. But really, we're looking at whether an adenoma was seen in the bowel segment of the original index colonoscopy, and was the colonoscopy adequate or not, as defined by intubational bowel prep. And then a further question, yes or no. And we have categories A and B: possible mislesion, examination adequate; possible mislesion, examination inadequate. Just advance, please. And we see that in these two categories, in this very large cohort of patients who have a post-colonoscopy colorectal cancer, this is for all of England, and 1,724 post-colonoscopy colorectal cancers, the largest sample to date, 86.4% of them were probably related to a form of inadequate examination. Either there was a mislesion, or the examination was not good enough to see the lesion, and we'll come on to that in a minute. So David and John, do you have any comment on this?
Yeah, I think that is this whole webinar, isn't it? That 86.4%, and the other two parts, which we have lots of material on, and which are for us very important, as shown here, are less important. John.
Yeah, I agree. I mean, the other point to make is that every procedure is a potential screening test. So whether you're doing it for symptomatic investigation, or you're looking at reevaluating something like colitis, this is still a screening opportunity. So basically, every time we do a colonoscopy, it is a screening colonoscopy.
I think that's the most important comment tonight, and I don't like to attribute the most important comment to John Anderson necessarily, but that is potentially the most important comment tonight, because, and I first heard that comment by a guy called Tony Axon from Leeds, and it was his son, believe it or not, who developed the endocuff. You may not know that, but I remember him saying at a DDW, he said, really, we need to consider every examination we do a screening examination. We're not doing the examination just to find a cause for the symptoms. So yes, next slide, please. So how can you perfect your technique? Well, this is, if that's the most important comment, this is probably the most important slide, really, because it really summarizes everything that we do. And all the hyperlinked items on these lists, we're going to cover in the presentation in one form or another, but we're also going to be showing you some slides, a video of two withdrawals that John did last week. They haven't been chosen for perfection. They're just the two consecutive patients, but just to show you some of the things that we're talking about here. And very briefly, obviously, prep is critical. Mike Burke in GIEQs last year, the Symposium, really emphasized the importance of use of simethicone. He very low tolerance of bubbles in the colon. We need to get our technique right, and we'll be covering all these things. And I'm really passionate about that third column. We get distracted, we get tired. We're dealing with multiple pathology. Our attention is really being strained. Some of us are working all day doing 10 or 15 colonoscopies in a day. And we sometimes have patients who've got a really high risk colon and they need extra special attention. And then, of course, we have the fancy technology coming forward. But I'd put it to you, if we don't get these things to the left of that final column right, the use of the technology, particularly artificial intelligence, if you're not visualizing the whole colon, the AI is not going to do the job for you. So basic techniques using with a clean colon and being aware of your own self when you're scoping and being tired and distracted is really important. Next slide, please. So I'm just going to hand over to David. So let's move to checking difficult locations. So firstly, the Seacom, next slide. And we're going to go through this pretty quick. So I think anybody would agree that that is the Seacom. Next slide. But in the same patient, when we look a bit more carefully, and this is one of my patients, we find a cancer behind the ileocecal valve. I guarantee this is the same patient as the previous slides. Next slide, please. So it's important that we visualize the cecum, not just intubate it. So just think about that. And John talks about lawyer's triangle, which is the part of the cecum which lies between the appendix orifice and the ileocecal valve. And this cancer here is sitting in lawyer's triangle. Next slide, please. And this is just, this one is just amazing here. So just look at this picture of a cecum. You can see the appendix orifice, and just in front of it, there's a lesion there with a slightly depressed center. And we've got a nice NBI view as well. I mean, nobody in the world would say that that is not a polyp. And the patient was on rivaroxaban, and so it's decided not to take the lesion. We can debate whether that was the right decision at the time, but the patient comes back a month later. Next slide. And I won't say who did this procedure. This is in our own unit last year. But this person said, there isn't a polyp in the cecum. I can't find one. If you look at that top right-hand picture, you might just see the lesion there. Can you see it? That's probably the lesion. Where you can see that there with the benefit of knowing what that thing looked like. But if you now look at these other pictures, really they're inadequate. You know, basically, if you next slide, what has happened here is if you look on the image of the patient is in persistently the left lateral position. And we're going to show you later that the left lateral position with the tip of the scope pointing so medially is the wrong position, and the cecum is often full of fluid and you won't be able to distend it properly. And John's going to show you on the video later that really that you want the patient on the right lateral if you want to visualize the cecum properly. And had this endoscopist done that, then that lesion wouldn't have been missed. Now, fortunately, purely by accident, I picked up that this had happened, and the patient's going to have another colonoscopy. But the patient may have just been reassured and come back, you know, 5-10 years later with a cecal cancer. Next slide, please. And here's another example of a post-colonoscopy colorectal cancer in the cecum. And that top picture, you could say, well, they've reached just above the ileocecal valve. Everybody would agree that's the ileocecal valve. They haven't looked into the cecum, and there's fluid there, and they were